Hi everyone, today we're looking at a CT head and CT angiogram for a 65-year-old female patient that is presented with a 4-hour history of sudden onset right-sided weakness. In the context of these query stroke presentations, when I'm looking at the imaging, one of the first things I look for is whether there's any intracranial hemorrhage. This is a really key finding to pick up on because it's a contraindication to thrombolytic therapy. So something that the stroke clinicians really want to know about. And when I'm looking for hemorrhage, I'm making sure to scroll all the way to the top and all the way to the bottom of the scan because it's possible to miss really tiny amounts of hemorrhage sitting right in these locations. Now, scrolling through the study, I can't see any hemorrhage, but something else is catching my eye. And say, for example, if we leave it on this slice here, we can see that there is a big warning light flashing up here within the left sylvian fissure that we're not seeing on the right-hand side. And this is a hyper-attenuating vessel, a vessel showing much higher attenuation values than we would expect. And as we scroll down, this would be an M2 segment branch of the left MCA. And as we scroll down one more slice, we can see that actually a lot of this M1 segment of the left MCA is also hyper-attenuating when compared to the other side. Now we can see this visually, or we can measure this and look for values of Hounsfield units around 70 plus. Now we've seen thrombus, or what we think is thrombus within the left M1 and M2, and that would fit with the pattern of the patient's symptoms. They're presenting with right-sided weakness, but we also have to look for areas of established infarct. And as we scroll through a lot of the MCA territory on the left-hand side, I can't see any evidence of established infarcts here. The grey-white matter differentiation looks pretty well intact. But when we come down to look at the insula, we can see that we've lost the nice insular stripe, or insular ribbon, which we can see on the right-hand side. We've lost that definition on the left-hand side. And that's in keeping with acute but established infarction of the left insula. The basal ganglia structures, otherwise, for example, the head of the caudate and the lentiform nucleus, they appear intact. So now moving across to look at the angiographic images, we can see when we're looking at the left MCA compared to the right MCA, in the left MCA we get the impression of a filling defect starting around here and filling the rest of the M1 segment. So part of the M1 segment here is still pacifying with contrast, but big chunk of it isn't. And that thrombus or that filling defect can be seen extending into some of these M2 branches. And as we scroll up to a higher up slice, we can see there's just no filling of vessels here, almost anywhere within that MCA segment. Unfortunately, the scan finishes here. I can't scroll any further up to fully classify the collateral status the patient has, but even looking at this side alone, it doesn't look like they have fantastic collateral circulation supplying that MCA territory. Ordinarily, I would also look at the aortic arch and cervical vessels, but they weren't included on this study either. So let's try and put together a report. Hyperattenuating left M1 and M2 segment. Acute established infarcts within the left insula. The rest of the left MCA territory appears normal. No intracranial hemorrhage. The CT angiogram images confirm left M1 occlusion. The aortic arch and cervical vessels were not imaged. Conclusion: acute left MCA territory infarct with left M1 thrombus. Okay, now the stroke clinicians in a lot of departments like reports written in a very structured way, so I'm going to use my CT acute stroke template here to generate a report from what I've dictated. And that will take my findings and put it in the format that I have dedicated. So this is a structured reporting format. And let's just check that it's got everything in here. Fine, we can probably bring this conclusion down a little bit, and we can leave it at that.